Well, hello. Thank you so much for joining our webinar today. My name is Suze Schrant, and I'm joined by my wonderful team, Mark Graber, who is the project co-PI and is the founder of SIDM, the Society to Improve Diagnosis in Medicine, and Marie Jaffe, a somewhat new member of our team. We're so lucky she was with us on this project. And I serve as the Senior Patient Engagement Advisor to SIDM and as the project PI for this work. So we're going to spend some time today just talking about all that we've learned through the course of this work. But we want to start with just a quick background on diagnostic error. I guess there is no such thing as a quick background. Wanted to give you some foundational information in case this is not an area familiar to you. Wanted to talk about why we did this project, the goals behind the funding for this project, what we've learned. And then because it's a PCORI funded study, one of the things that necessarily results is what do we think should be studied now that we've identified these prioritized research topics? So we'll talk about that. And then most importantly, we really want to hear from you. We want to hear your feedback on our findings. We want to hear what research areas you're interested in, maybe the research that you're already doing. And so we really encourage you throughout to enter questions into the Q&A. We will pause midway through to take some questions, and then we'll save time at the end to take questions as well. So thank you so much for joining. We want to get a sense for who is in the room, in the virtual room today. And so we're going to start with a quick poll. And so Marie, if you can launch our first poll, just want you to respond based on your stakeholder type. Would love to know who has joined us, and we'll give you all a minute to respond. Okay. Still some votes coming in. We'll give it another minute. Great, we've got a great diversity of folks on the line. Okay, that's probably good. Can we see the results, Marie, or end polling? Great, okay. Wonderful. Well, thanks so much. That helps us just know who we're talking to, since we unfortunately can't be in the room together. But great to have all of you with us with that great diversity of perspectives. At this point, I want to turn it over to Mark Graber to talk a little bit about diagnostic error in general, sort of the background for this project and for the work of SIDM. So Mark, I'll turn it over to you.
Thank you, Susan. Welcome, everybody. How are we doing on sound? Can you hear me okay?
Sound great.
Thank you. We can get the next slide. Great, thank you. So, well, I think everybody kind of knows the story about diagnostic error. This is a huge problem. It's SIDM's major focus. We'd like to make sure diagnosis is safe and of high quality everywhere. I think most of you have heard the statistics about diagnostic error. We're pretty sure that 1 in every 10 diagnoses is wrong. From Hardy Singh, we know that 1 in 20 primary care patients will experience a diagnostic error every year. And there are estimates that at least 40 to 80,000 patients a year will die from diagnostic error in the United States. And by now, I think you're all familiar with the estimate from the National Academy. It's likely that most of us are going to experience at least one diagnostic error in our lifetime, and some of these are going to have devastating consequences. So this is a very common problem. It's a very scary problem. And according to ECRI, it was the #1 patient safety concern in the United States in 2018. They reiterated this in 2019 and a final time in 2020. So a big problem. And this was in the good old days when we had in-person healthcare. Next slide. So what we'd like to tell you about today is the project we've been working on to study telehealth and how it's being used for diagnosis, because this is a major game changer in every sense of the word. Everybody is aware of the explosion of telehealth use over the last COVID year. And we've been interested in how this impacts diagnosis. Turns out telehealth has been used for a long time, decades actually, in some niche areas like radiology and dermatology. But what was new during the pandemic was its use in frontline ambulatory settings, primary care, pediatrics, family medicine. And in these settings, using virtual care for diagnosis was really completely novel. Pretty much a new thing for everybody, for patients, for clinicians, for the organizations that were trying to provide healthcare to their patient populations. And from our perspective at CITM, we were very interested in what's the bottom line here? Is this good for diagnosis? Is it bad? And the answer was not at all obvious up front, because you can think of good things and negative things for every single step of the diagnostic process that telehealth might impact. So for instance, just the first step, access to healthcare, you might think that, well, telehealth is great for access because it makes it so easy and convenient for patients to see a provider. And patients overwhelmingly love this mode of healthcare for those who are able to use it. But on the dark side, what if you don't have a computer, or you don't have a tablet or a smartphone? And studies have shown that 1 in 3 American households do not have internet access at this point in time. So what happens for all those patients? And these trade-offs play out throughout the diagnostic process. So telehealth is great for improving follow-up, but it's terrible if you need a physical exam. What's the bottom line? What's the net impact? That's what we were interested to study. So in this study, we were pleased to get funding from PCORI to look at how telehealth is being used for diagnosis. We approached this by doing a literature search and interviews with key stakeholders. We identified 5 separate stakeholder groups that we wanted to talk to: patients, clinicians, practices, hospitals and healthcare organizations, and companies that were providing telehealth services. Each of these has a unique perspective on telehealth, and that's what we wanted to learn more about. Next slide, and I think back to you, Suze.
Okay. Great. Thanks so much, Mark. So with that sort of background on both diagnostic error and a little bit on telediagnosis, wanted to again kind of hear from the folks in the audience about what your experiences have been. So we're going to ask a second polling question. Want to first get a pulse on what have your experiences been with diagnostic error? And this can be your personal experience or your professional experience. So go ahead and let us know, how prevalent this has been among our audience today. Oh, wow. So pretty significant number of people with exposure, which is not surprising given what we just learned from Mark. Okay, that's great. Thanks, Marie. And we can end this poll and then go to the next one. And this is more about the use of telemedicine for diagnosis, which is what we call telediagnosis. And so again, this could be personal or professional. We just really want to understand, have you used this? Have you tried to get something diagnosed as a patient or as a professional? Have you tried to make diagnoses virtually? What does that look like for you? It's great that it can calculate in real time and sort of jump around on the screen like that. Okay. A little bit of variance then. Okay. And this really matches a lot of what we heard in our work, that it's a really variable question. Okay, that's great. Thanks so much, Marie. Can you show us the results? All right. That's great. Thank you. Okay, so doing a deep dive now into sort of the parts of the project, and Mark just gave a great overview of the ways that we tried to tackle this question. Mark, I'm going to give it back to you to give us a deeper dive into the literature review. Maybe tell us how this went and why it was maybe a bit of a challenge given the attention and focus on this topic right now.
Yeah, thanks, Sue. So the first step in this project was an environmental scan. I think that's a more accurate way to describe this. And we focused mostly on the past few years, and we focused on telehealth in primary care settings. So we did not look at surgery. We did not look at the medical subspecialties. And both of those would be wonderful topics for a follow-on project, but not for this one. We first tried to find some systematic reviews, and we found 35 that were related to ambulatory care. We looked back 3 years in Medline and found 310 relevant publications. And I think the most interesting part of this whole search was the gray literature aspect, because there are blogs and white papers coming out every week on telehealth and about telehealth for diagnosis. And it's been a challenge to try and keep up with this rapidly evolving field. But I think we have a very nice background, at least in terms of what's been written about the topic. And it was very helpful in setting up the discussions we had with our different listening session groups. And back to you, Suze.
Thanks so much, Mark. And yeah, it just the speed with which information was coming at us, I think was both a great thing, but maybe a little bit of a challenge as we were working on this. We also assembled just a rock star cast on our advisory team, touching upon those three stakeholder or the five stakeholder groups that Mark already mentioned. Obviously, patients and caregivers at the forefront. So we had representatives from four different patient and caregiver organizations, including CITM's own Patient Engagement Committee. We had clinicians represented as well as clinical practices. And we looked at those a little bit differently. Clinical practices more about sort of systematic functions and how the office operated versus individual clinicians' experience. We also had the telemedicine industry, so companies, vendors, platforms represented, and then hospitals and health systems. And I can't say enough thank yous to this group. They were truly phenomenal and have been informing the work at literally every stage. So we're very grateful to them for their time, energy, and expertise. So in terms of, what were we trying to find out? What was our line of questioning? And especially in the earlier listening sessions, because we were still really right in the teeth of the pandemic, we wanted to know, especially from hospitals and health systems, from clinical practices, what did it look like to just do this rapid upscale of telemedicine? And how did that work for diagnosis? How were you making heads or tails of the clinical symptoms you were encountering and the patients you were talking to? We also, in most cases, asked about, was there anything that you wish you had known in the beginning? Some things that you sort of figured out along the way? And I think universally, yes, there were always lessons learned that might have been helpful back in the beginning. We were always very interested in learning sort of tips and tricks, and we'll share some of those today, some really creative methodologies, especially in those early days when it really was difficult to make in-person visits happen. On the patient side, understanding from the patient and the caregiver perspective, we wanted to just understand how the experience was different. So do you prepare differently for virtual visits? Do you think about them differently? What has it been like if you've had a new issue or a new symptom that you were trying to get diagnosed? And then we, across the board with all of our stakeholders, really wanted to understand some forecasting, looking ahead. Do we think virtual care can and should stay around? Will people be interested in using it? And then importantly, are there certain things that, telehealth or virtual care is particularly well suited for versus things that it's really not well suited for? And there were many, many more questions. This just gives you a flavor for the types of conversations we had across these various listening sessions. This is just a snapshot of what's been done to date. So Mark talked about the environmental scan that really has informed everything we've done. And it also informs the summary issue briefs that we've been producing. We then launched all of our listening sessions. So we had the 5 different stakeholder groups that you see described on the screen: hospitals and health systems, clinical practices, clinicians, telemedicine companies, and patients. And that work spanned from December of 2020 through to just this May of 2021. So a lot of work in a short amount of time. And the goal was to talk to 10 different representatives within each stakeholder group. So we had quite a robust collection of insights from our 50 different listening sessions. In the summary briefs, the goal for each of these issue briefs or summary briefs was just to capture what was heard in those conversations and sort of to show the overlap with the existing literature. So each brief really has two components. We released the hospitals and health systems brief along with the clinical practices brief. We actually combined those because so much of what we heard was similar. The upscaling, the just adjusting to this new method of care was all quite similar. So we combined that into a single brief. The clinician's brief is in progress right now. It should be done in the next number of weeks. And then upcoming, we will be releasing our brief on the telemedicine companies and platforms sessions. And then finally on our patients and caregiver sessions. And then of course, you all are part of our diagram here. We are having our webinar right now, which is actually going to help inform our final issue brief or final report that's going to cover the entire project, including what we hear from you all today. And we really appreciate that opportunity to iterate and keep building on what we're hearing. So this is a link to that first issue brief that combined hospitals, health systems, and clinical practices. If you hadn't had a chance to see it yet, this is where you can find that. And in terms of the findings, and we only have an hour, so we're going to try to give you just the top line findings, but my goodness, we have learned a lot, and in many cases raised more questions than we even anticipated. So I wanted to try to just organize what we heard into a couple buckets to just make it a little bit easier to sort through, because I think there were some kind of clear divisions from the conversations. Certainly the technology itself, and this is an important distinction. Anytime you talk about telemedicine or telediagnosis in particular, are you talking about the technology, the tool that we're using, or are you talking about the care that ensues? And so this is about the technology. The second piece is then the component to that, the companion, the clinical experience. What was it like to receive care like this? How was the diagnostic process in particular affected? And sometimes that really needed to be kind of extrapolated from the clinical experience. Sometimes it's hard to think specifically about diagnosis within a given clinical encounter, but we really tried to pull that piece out because that's what our focus was. And then there's some findings really about how we measure. Can we measure? Who's doing a good job measuring effectiveness of the use of telediagnosis? And then, as I already mentioned, just some forecasting. We really want to know what's going to change and what have we learned that we can sort of take with us and carry forward. So I'm going to walk through the findings kind of based on these categories. And I do encourage you, if you haven't already, please enter questions into the Q&A or even into the chat function. When I get through this body of findings, we'll pause and take your questions. And Mark and Marie, I, of course, invite you to jump in with any comments or additional thoughts on any of these slides. So starting with the technology, I believe I said this on the last slide, just incredibly rapid expansion during the early months of the pandemic. By the time we were talking to people in our December sessions, they were in some sense catching their breath. They were talking about it almost in past tense, that they had gone from 12 telehealth visits a year to many hundred. Sometimes the figures were really staggering, that growth. So that was sort of a universal, this was a catapult into a new way to provide care and diagnosis. Definitely a very clear difference between hospitals or systems or clinics that sort of had an existing infrastructure, were already figuring out ways to use telehealth. And you can imagine, in rural areas where they're always sort of set up to do this, or in clinics that have just for whatever reason already incorporated it, they had a bit of a head start. They could sort of lean on what they'd already built versus systems that were starting completely from scratch. And this also translated into size, understandably. So very well resourced, larger clinics, larger systems, hospitals, et cetera, sort of had a little more room to figure out how to make this work and how to finance it versus some individual clinics. We talked to some individual clinicians who really were literally figuring it out step by step as they went along. I think in general, patients are incredibly appreciative of the convenience. And when we asked the patients to sort of look back and think back in time, or even think about the current day, were they fearful of in-person visits? I think there was a lot of fear. We heard a lot about, yeah, I was grateful that I didn't have to go in. So it was both convenience because I'm not interrupting my day, but also it's kind of saved me from having to go in. And in fact, this came up in clinician and clinical practice conversations as part of a challenge. So if you had a patient that you were seeing on telehealth, but you really needed lab work or you really needed some sort of diagnostic imaging, there could be a reticence for that patient to want to go in and do that. We hope that's lessening now that we're slowly seeing vaccination rates rise and learning more about transmission, but that was a notable issue. And then one thing that I think, and Mark sort of opened this up in terms of accessibility, there really didn't seem to be a clear profile for the type of patient that's well suited for a virtual visit. I would admit that going into this, I sort of had preconceived notions about, well, young 20 somethings who are already very computer savvy are just going to totally understand this and love it. And maybe folks in their eighth or ninth decades who did not grow up with technology are not going to be great. But then we would hear from clinicians saying, actually, as it turns out, I've got some 90-year-olds that are loving telehealth, or I've got some 20-year-olds that are not doing a great job. So it seemed like there wasn't a way to draw a nice diagram around for whom it worked and for whom it didn't. I think there's a lot more research and literature coming out now trying to sort through that very issue.
Suze, this is Mark. I'll just jump in there on that one and kind of emphasize that point you made about the elderly. On the one hand, there was very clear data in the literature that the penetration in terms of elderly usage was less than that of younger age groups. But as you pointed out, there were all sorts of anecdotes. I said, well, this was the first time grandma used her smartphone. So, the yin and the yang of this just played out over and over again.
Absolutely. Thanks for that, Mark. So kind of looking at then the companion to the technology is the actual clinical experience, right? So here again, just a lot of yin and yang, that's a good term for it. So there was a wide divergence of opinion. We actually heard from a lot of folks that somehow virtual care even felt more face-to-face. It felt like there was more attention paid between me and the clinician because it's just us. But then there were other clinicians or other patients who felt like, nope, I'm still missing that human connection. So it's hard to figure out what that sort of exact variable is that we could have that divergence of opinion. But that takes us into the next bullet, which is really interesting, that there's also a trade-off between, can I see into someone's home and understand where they live and at this point work, because most of us are working from home, and does that help me with my diagnostic process and sort of understanding who this person is and what their life is like? But again, we go right back to the trade-off, which is I'm not able to evaluate that person in my office. I can't watch body language. I can't see other signs. And we even heard this. I remember a notable conversation with someone who does psychiatry. And she said, typically the virtual visit works because I really want to talk. I want to be able to just communicate and deal through emotions. But there were certain patients that she really needed to be able to watch their body language and understand how they were feeling. And that helped sort of paint their diagnostic picture. So here again, just kind of this interesting conundrum. One of the things, and I won't speak for Mark and Marie, I will say I was surprised because I wasn't as informed about remote patient monitoring, but this is something we ended up learning a ton about. And this is not necessarily, strict virtual visits or even phone calls. Sometimes it's truly just staying in communication or a nurse or a nurse practitioner receiving test results or monitoring A1Cs and paying attention outside of visits, that seemed to really provide a greater continuity of care, made the patients feel more supported and more sort of paid attention to and watched. And from a diagnostic lens, that's a great opportunity to make sure you're catching something before before a condition is exacerbated or if something looks amiss. Having that remote patient monitoring was a really interesting sort of stream of what we ended up learning. Um, and then I would say, again, a diversity of experiences with how you recreate or don't recreate the team environment. We heard about some really cool concepts where you could have, if you see a lot of specialists, you could all be on Zoom together talking in a single appointment, which saves a lot of time. That's an incredibly efficient way to do that. There were even some examples of sort of walking the patient from room to room, if that's the right way to describe it, because they needed to see different practitioners within a particular office. But there were other examples where that team just hadn't quite been figured out. Maybe that's just a matter of time, but definitely a divergence of opinions and experiences here. Anything on this topic, Mark, that jumped out at you?
Sorry, Suze, I was busy on the chat.
Oh, I'm sorry. Okay.
Yeah, the thing that jumped out at me was the creativity that the provider clinicians came up with, and they're appearing every week. Here's how to do the 25 steps of the ENT exam. Here's how to do a detailed neurologic exam, which is amazing because the neurological exam is one of the most detail-oriented and extensive things that you could ever do to a person seeing them in your office. And to be able to recreate most of the elements of that virtually is really quite astounding.
Yeah, I totally agree. And in the diagnostic process, actually, I'll share a couple of those examples I think here, so that when it was when there was this inability to perform a physical exam, which was cited often as a key challenge, depending on what the chief complaints were, there was a lot of creativity, the assessing strength by watching someone pick up different weights, or assessing someone's ability to do a walk test, or just really quick and creative thinking to try to figure out how to get that information in the only way that you can. Virtual care in many cases, I think this came up quite a bit, allowed you to do a little more intimate follow-up. So if you've made let's say a provisional diagnosis and you want to kind of keep checking up on the person, there was something about these new lines of virtual care and the new comfort with it that made it feel like you could do that in a little more efficient, easy manner, kind of touch base with the patient, check in, see if your diagnosis was on. When available, digital tools, and some of these digital tools were really cool. Mark, I think you were leading that session. We learned about a new baby shower Rage was this baby monitoring tool, and people were putting it on their baby registries because it was such a great tool for pediatricians to rapidly feed data right into the EMR or whatever the platform was they were using. But here again, when those things were unavailable, clinicians just got really creative. Many patients reported this was something that I really it's just jumped out at me in our many patient and caregiver sessions, was that there was sort of a cohort of patients who talked about they did their own triaging now that there is some in-person opportunity available. And they would kind of decide whether they needed to be seen in person or virtually, if it was their choice, I should clarify, based on what they thought would likely ensue. So if they knew they were going to have to get labs, or they knew they were going to have to, get an x-ray, they said, I'd rather just go in. I'm going to be there anyway. I'll have it done. Versus if they thought, well, this is the same ear infection my son has had 20 times. I know that's what it is. I know this pediatrician, we have a relationship, we'll just do it on telehealth. I thought that was a really interesting patient side of the equation, that there was a group of patients that had sort of figured that out as their barometer. Mark, anything on the diagnostic process? I'm trying to think of more examples of those great creative solutions, and
Well, the one I remember was the clinician who had his elderly patients hold up a can of Campbell's tomato soup to see
mm,
if their muscle strength was okay. And it was a little bit out of scope for us. We didn't really study M health, mobile health, but you're absolutely right. This is going to create a huge market for things that patients can have at home so that their blood pressure or their, I don't know, their oxygenation, you name it, can be monitored. And a lot of that is for monitoring over time, not necessarily for, first time diagnosis, but this is all interrelated.
yeah, yeah. In terms of measuring effectiveness, I think, if I think about even just the arc of the questions that we asked, I think our questions sort of changed over time because right out of the gate, we really wanted to understand who's measuring and how do we know what's working and what's not working. And I think early on, it was still really, really hard to be measuring. So we didn't have a huge number of very specific measurement examples. There was a lot of customer satisfaction surveys and clinician satisfaction surveys. Now, how's the technology working? How is this feeling? But when we think about how do we really measure the effectiveness in terms of diagnostic quality and safety, I think there's a lot to be done there. And we'll actually talk about that in the second segment in sort of the under the ambit of what are the research questions we want to have answered. There's been a ton, as Mark already said, of promising and best practices released by clinical and research professional societies. I think there was such a hunger for guidance and for anything people could access, and so there's been a big push to get that sort of that work out there. Um, I think patients certainly have, again, just that convenience, just largely positive views of convenience and efficiency, but definitely the yin and yang again, a concern about I'm not sure virtual care is right for every symptom or every issue, and sort of that concern around how do I know which is which? How do I know when this can be managed virtually? And then in terms of forecasting, so looking ahead, I would say, Mark and Marie, I don't know if you'd agree with this, but I would say I think there's pretty universal support that there is a place for telehealth. I think that's a line we heard a lot. There is a place for telehealth, and everyone wants to keep it in some way. It's just a matter of how and where. Where does this fit in our toolbox? The ability to get reimbursement was absolutely huge. We kind of went into the project expecting a little bit of talk about kind of policy, coverage, reimbursement. It came up all the time, so this was a big issue. Patients had varied experiences with payment and co-pays. One of the things we heard, it was only a few times, but I think it's actually a really important thing to kind of draw out, was a concern around almost a duplication in billing. Goes back to one of the findings I mentioned a minute ago about when a patient thinks, well, if I'm going to have to get lab work or get an x-ray to confirm this diagnosis, I might as well go in for an in-person visit. There was a concern around if I have a telehealth visit and I get billed for a telehealth visit, and then it's decided now I need to go in for another visit so that I can get lab work or however that would pan out. Does that in some way sort of duplicate the experience? Are you now paying for two things instead of one? So there's probably quite a bit to sort out in terms of how we organize and build plans and health plans around telehealth. And then we didn't get super deep into things like HIPAA, but the general relaxation of regulations that happened sort of early on allowed for that easier and more rapid upscale, which I think was probably really important. But there's definitely some lack of clarity, particularly among the clinical sector. I don't know if the patients were as tuned into this, around what will it be like? Are we already retightening these regs? What will it look like when we do? Are there certain platforms we're going to all of a sudden not be allowed to use? So just a lot of questions from the clinical community side around what the future of that looks like. Okay. So with that, we're at the end of our first kind of bank of information. So let's see. I've got, did we answer one already? I should let Marie be in charge of this because I'm not very savvy. We've got,
Questions? Yeah, there's one it's under answered. Do you see that?
yep, okay. First, was the positive response regarding face-to-face service with the medical provider connected to spending a greater amount of time with the practitioner? This was so in our case. So great question. And I think, and Mark and Marie, please chime in. I think there was a, sort of for the people, and I'm thinking from the patient perspective, from the patients who reported that it felt like more of a human connection, there was already a connection with that provider. This wasn't a first visit. And it was sort of the removal of the typical noise that's happening in it. And I don't mean literal noise, but just activity. And so you could sit with this person and really just focus and have a conversation. Something that came up on the clinician side was you're not entering into an EMR off to the, you're not facing your computer, you're facing the patient. So I think there was a couple reasons. Mark, anything else on that question that I'm not thinking about?
I think those were the main things, Suze.
Yeah. Okay. And then in the open questions, we've got, did you find any practices that were doing real-time QI with patients as visits occurred, asking them what worked well and what would have been better or what could have been improved? That's a great question, Mark. I'm trying to think if
We heard almost nothing about that. So this was so new everywhere that places were just happy to be able to get it up and running and had really not invested in studying the outcomes. I think the one exception were a couple of companies that have been providing telehealth services for quite a while. So a couple of the companies did more detailed quality assessments, but that's really what we need going forward. We need people to start measuring this and looking at the outcomes and, was this good for diagnosis or was it not? Did the diagnosis change? Did it speed up diagnosis? Did it slow it down? One thing we heard a couple of times was that telehealth actually accelerated the ability to get a consult from a subspecialist. And in one system, it was really amazing. They had a setup where you could get a subspecialist to come right in on the call as you were having it with the patient, which I thought was amazing. And just think of the days and weeks and months that would save. Because in the system I worked in, you sent in a request for a consult and, maybe there would be availability in a couple of weeks or next month.
Yeah, that was a big, a really exciting finding, I think. So there's another question here. I keep finding discussions where clinicians assume the visit will be provided by the patient's PCP or specialist within their care system. Are you investigating fragmentation of care if pharmacy, nurse, NP clinics, or Amazon are inviting patients to call for their telehealth visits and the impact on care overall? And I think, we didn't specifically ask I'm trying to think of the exact questions we asked. We uncovered a little bit of this in the patient sessions, that there was a different sort of sense about continuity of care if you were having a telehealth visit with your clinician that you already knew versus sort of dialing into a system. The convenience factor was equal. It was wonderful to be able to sort of access a clinician quickly, but there was some question about who's talking to who. Mark, thoughts on, we didn't really look specifically at this beyond general coordination and team-based care.
Yeah, Susan, it seemed like the big healthcare organizations really did a good job. Everything was well integrated. Some of them, the telehealth visit was very well integrated with your electronic medical record. It went right into your own notes section and you could see those notes. But I think the fragmentation issue is huge and really important. And it's going to be a big problem going forward because there's so many small outfits that are providing direct to consumer telehealth, and they're not integrated with your own primary care person. They're not integrated with your healthcare system. Your notes are going to be in one place and may not be the same place you're getting the rest of your care. And I think fragmentation is going to turn out to be one of the big negatives about this whole story.
Yeah. So we have a question here. Did you hear from some clinicians and patients that they were able to utilize telehealth to catch up on visits that the clinics were behind on? And then she adds also behavior health, she has heard has been successful. And I do think universally we've heard really positive things about behavioral health, that it has been a great way to expand access to behavioral health, always with caveats, but in general, that's been good. I don't know that we asked about telehealth as sort of a catchment for not being able to get into a clinic. Mark or Marie, something we could go back and look at.
There were several publications that looked at the use of telehealth versus in-person care week by week during the pandemic. And there was a lag for sure. I think it was February and March, all of healthcare took a big dive. And then all of a sudden there was, telehealth clicked in and there was a big, huge spike in the use of telehealth. The interesting thing in all that was that if you added up the telehealth visits and the in-person visits, it did not match the amount of healthcare that was taking place before COVID. So that gap is been seen in study after study. And that's all the studies that are showing that there's going to be all these delayed diagnosis of cancer because patients didn't come up with their screening, patients presenting later in the course with their appendicitis, patients presenting later in the course of their heart attack. So the timing aspect of it was really interesting.
A question here about timing, and Mark, I think this is mostly going to come from the literature because I remember you talking about this. Mark mentioned access via the internet earlier, and I'm interested in time of day. When comparing our typical clinic or office hours, was there any expansion of the clock via telehealth, meaning patients or clinicians were more likely or more interested to engage early in the morning or late in the afternoon? And I'll answer quickly just from the listening session perspective. What I heard from patients was not necessarily about being able to do it earlier or later. It was simply the act of not having to get dressed up and get in a car and go find a parking space and go to a visit. And so one young woman who's a mom of 3 young kids talked about, it's such a game changer for her. So it didn't matter that it was smack in the middle of the day because it was only 20 minutes and not 3.5 hours. So to me, that was a big finding. But Mark, what has the literature said about this?
I don't recall seeing a single thing about, change of hours during the day. Be interesting, people listening in, use the chat. Did anybody have an experience where they tried to use it after hours?
Yeah, that's good. There was something about in the literature, maybe about just sheer amount of time, like does telehealth take more time or is it more efficient? But that's not quite the question that he's asking.
Yeah, that was something we asked a lot of people about. And as I recall, the answers were it took less time to do a telehealth visit. And maybe that's because they skipped the physical exam. I don't know. Or maybe it's just a more efficient way and you're not distracted by looking over at the computer, as you pointed out. But that's another thing that would be very interesting to study. Is it more efficient or less efficient?
Yeah. Was there any information on patient compliance with treatment with telehealth versus in person, one being easier and more conducive to compliance than the other? I know we heard from several clinicians and systems about the way they were evaluating keeping appointments. So that there were changes in not, what is the word I'm looking, I keep wanting to say recidivism, and that's not the right word, but maintaining their appointments. And then I would say the only thing in terms of sort of compliance with treatment on the patient and caregiver side, I would say one area may be worth doing a deeper dive and expanding a little bit is that there could feel like a bit of a drop off at the end of a telehealth visit that there isn't in an in-person visit. You sort of check out, or the nurse comes back in, or you get your papers. Some people had a good experience, but many others said it just sort of ended, and it felt a little more like a drop off than kind of the warm handoff when you're in an in-person visit. Mark, any thoughts on this one?
You know,
Or
the thing
Marie, were you saying something?
thing that struck me was the potential for better and easier follow-up using telehealth. And that's huge in diagnosis. You know, you're lucky if everything is totally clear at your first visit, but very often your symptoms evolve, or it's important to know how you responded to treatment, or you need to follow up after a test. And it seems to me that telehealth is going to be great in terms of improving follow-up. And in that sense, I think it really could improve diagnosis.
And in some of the sessions that I did, we heard a lot about maybe the human interaction ended right at the end of the appointment. However, depending upon how robust their EMR was, all of the follow-ups took place through the EMR or through the patient portal. But if their system wasn't robust, in a lot of cases, the patient actually had to call back in themselves and schedule their follow-ups or schedule their testing. So maybe the human interaction ended in a lot of cases, but there was some continued follow-up in the EMR based on its functionality.
Yeah, yeah. And we have a question from, or a comment from Ruth about the biggest impact for her with telehealth is a visit to do something simple like renew a medicine, eliminated the travel time, waiting in the office, waiting in exam room, and that's a huge improvement. I think that's exactly those types of visits where you're not trying to get another diagnosis. That can be a real magic spot for telehealth. Were any of the practices putting questions on their intake forms about whether a patient was computer literate and or their level of use of a computer device? I'm guessing, I'm kind of adding to this that would be maybe before a telehealth visit is decided upon. I don't recall seeing that.
A couple of the clinicians were telling us all their struggles about, you know, at the start, trying to get this up and going with their patients. And it seemed like the places that were resource rich assigned like an administrative person or a nursing assistant or something to call the patient in advance and get everything set up on the patient side so that it worked better for the actual clinical visit. That's a very time intensive thing, but it seemed like it was key to make the whole thing work.
Yeah, yeah. I'm looking at the time. We've got about 12 minutes left, and we've got 9 open questions, and I'm wondering maybe we can divide and conquer and answer some of these by typing into the Q&A function while I go ahead and touch on the rest of the material. Maybe Mark and Marie, if you can be responding to Q&A, and then I'll try to move quickly through the rest of the material. I just want to make sure I get to it. But we also want to answer the questions. So let me just, I'm gonna go quickly through where we kind of landed with the key research needs, but please keep sending in the Q&A and we'll try to respond in written format. So as I mentioned, because this is a PCORI funded study, one of the major outcomes was what are the research questions that we really need to answer? Because that's what this really was meant to uncover. What do we not know that we really need to know? And I think from a very top line perspective, these are a couple of the ones that really jump out. So that triage question, I think, was what everyone wants to know. Who and what symptoms need to be seen in person and what can be addressed virtually? Is there a right mixture of in-person and virtual care? Where can virtual care really fill the right gaps? I think an immense question, and it came up right at the top, I think in Mark's first comments. Who is being left behind? And I think this is one of the things that was challenging in the work we were doing. We all knew as we were having conversations that there were people that weren't in these rooms, these virtual rooms, but we're not sure how to get to them and how to talk to them and learn what we don't know. So who is being left behind? And then what factors determine success or failure in telediagnosis? Is it about specific conditions? Is it about specific techniques? And how do we figure those out? If we look back in those sort of 6 buckets of topical areas based on what we heard and the research needs that stemmed from that, I'll just quickly go through these. So technology, back to those digital tools. What are the digital tools that are the right ones to use? How do we calibrate them? We don't want to rely on something that's not effectively calibrated and may not be giving us the right data. What do we do about broadband access, or at least making sure patients have smartphones with good plans or tablets with plans? How do we balance privacy with easier access to virtual platforms? And privacy came up quite a bit in some unique ways that I wouldn't have anticipated. So I think that privacy access balance is going to continue to be a tough one, and we have to figure out the right answers. In the clinical experience, that human connection piece, that yin and yang we talked about, some people thought it was great, some people didn't. So what do we need to know to better replicate that connection and make sure it really feels strong, feels good? Um, can telehealth simplify and make sort of those routine visits easier and more efficient? Can we almost route people depending on what their needs are? And how do we foster that virtual care team in this virtual environment? Looking at the diagnostic process, how do we determine and create guidance for that triaging? I mean, I think that's the holy grail that people really want. That's going to take a lot of research, a lot of work figuring out how to make those triage decisions rapidly and getting people to the right mechanism of care. Measuring effectiveness, and I will say at the top, we've talked a lot about this. Mark and Maria and I participated in a different event on telemedicine about a month ago, and we were asking things of telediagnosis that we haven't even asked of in-person care. We want to know right now whether the diagnoses are accurate, and how do we know the percentage of the time that they're accurate. And we kept realizing we're asking things of a brand new mechanism of care we haven't figured out for in-person care. But this could be an opportunity because we are sort of building this massive change. How can we best learn from this? One of the ways that has been used is these patient surveys, but what if we could ask in those patient surveys specific questions about diagnostic accuracy and follow-up beyond, was it a pleasant experience and did the technology work? And might it actually be a better way? Is there something we could build into virtual care that is in and of itself a tracking or reporting mechanism? And then forecasting, how do we make these coverage and reimbursement decisions now in the absence of a lot of this measurement data and measurement knowledge? Something that came up a number of times is just medical malpractice. We don't have time to get into that, but how is this going to work within that landscape? And then what about cost? Will use of telemedicine ultimately increase cost? What about diagnosis specifically? How do we start to capture that data? And then 3 big things, and Mark mentioned one of these really jumped out at me as just important things to sort of rally around because I think they're so important. One was just about that increased access to specialists, and this could be a game changer, especially for people with rare and hard to diagnose diseases. If there is more efficiency, is that something that could truly revolutionize the way that our healthcare system works? And then what about increased access to care, especially for the diagnosis of sensitive or stigmatized conditions, people who are not particularly mobile, people who are not able to get into a clinical setting? So there's a lot of opportunity. There's just a lot left to answer.